Welcome to another edition of Dr. Lanny Health Podcast. As you know, our general topic is to take a look at the art and science of discovery, but lots of times we can be discovering things that are not just positive going forward. And in this particular podcast, I want to go over what I call challenging what we know for sure. There are a lot of things in medicine that we know for sure, but don't actually turn out that way. So one of the things that we knew for sure about articular cartilage was it doesn't heal. And the reason is articular cartilage doesn't have a blood supply. That's true, but it may not necessarily be true that cartilage would not repair. So we know for sure if there was a cartilage repair, it would not last. So that was the next thing. First of all, he said it wouldn't heal. Then there was some evidence maybe it might heal. And so if it did heal, the reason it wouldn't last was that it would be fibrocartilage, and fibrocartilage, of course, could not survive in a synovial joint. Well, interesting enough, the meniscus is fibrocartilage and it's native to the joint. So here's some other contrary evidence. One is, I like to say that a series of one is better than a series of none. In discovery, you have to be alert to observation, and sometimes the first observation is not, of course, a clinical series of 100 cases with a 10-year follow-up. It may just be a single case observation, but it may lead to publications with a 20-year follow-up, which you'll see coming in a few minutes. So this particular case was a orthopedic surgeon resident, a friend of mine from years ago, and he tore the cartilage in his knee. And because I was one of the first people doing arthroscopic surgery, he came from St. Louis to Michigan, and we did surgery, and I resected the portion of his lateral meniscus. But during that resection, I made a slight incision into the articular cartilage, which really bothered me because of my ineptitude. But I didn't want to leave a flap, so I joined and cut out the other side of the where I had made the laceration. So I made a divot, V-shaped, in the articular cartilage, but it did not go all the way down to anywhere where there was a blood supply. So it was a lesion that we would know otherwise would not heal. Well, 6 years later, he had some arthritis in his knee. He came back, and sure enough, you can see on the arthroscopic view on the left, there was an area down bone to bone. But the area where I had made a small V-shaped resection in the surface of the articular cartilage had now sealed over, and I biopsied that. And on the right, you see the histochemical staining of the saffron stain showing mature articular cartilage at 6 years. So this was a partial thickness lesion that we saw had healed at 6 years in the face of arthritis, which is interesting. So again, I had my series of one that was better than a series of none. So it is true that articular cartilage doesn't have a blood supply, but it's not true that it doesn't have access to blood. So anytime there's an operation on the knee, or whether there's a joint or any other joint, that even by arthroscopy, that there'll be bleeding and blood clot formation, as you've seen in this arthroscopic illustration. And so I published a paper on the characteristics of immediate post-arthroscopic blood formation in the knee joint, and it was in Arthroscopy in 1991, whereby I established even when you don't see it after an arthroscopy, there is a blood clot formation. And so one of the fundamental things in a blood clot formation is that it has to house and hold. That clot has to house and be held. And so on the left, you see a full thickness articular cartilage lesion on the femoral condyle of a knee joint. And you can see that after the opportunity to wash all the other blood out, that there was a blood clot formed that was housed and held in that defect. And on the middle slide, you see after arthroscopic partial meniscectomy, you see that the blood clot formed on the inner border of the meniscus. And although on the slide on the right, the arthroscopic picture on the right, not from the same patient, but one similar, you see the fibrocartilage had filled in the inner border of the meniscus where there had previously been a blood clot. And so we see, even though articular cartilage or meniscus doesn't have a blood supply, it has access to bleeding and access to a blood clot, which can allow for maturation of the tissues subsequently and have healing. Now, a major pathological misunderstanding, is the blood supply is deep to the surface of the articular cartilage lesion. So where we have a grade 4 lesion where there's exposed bone, sclerotic bone, the history in the past has been able to drill multiple deep holes to get to the blood supply, which was presumed to be deep to that surface. And on the left, you see a photograph of what was called a pretty procedure, which frankly is not very pretty and not the best way to do that. But with that history of orthopedic surgeons know they like to drill and pound with hammers and drill holes, then the procedure called microfracture occurred and became very popular, as you see on the right in arthroscopy, where there are puncture holes made in the end-stage osteosclerotic lesion. And so we take a look at what tissue forms after a drill hole. And interestingly enough, this was from another patient who at 1 year had drill holes made in their kneecap, subsequently had pain, not my patient, but one referred, in which we see what a drill hole looks like at 1 year. And of course, the surface has sealed over with fibrocartilage, but still it's very active and it hasn't filled in with bone, and it's just one fibrocartilaginous plug. It is not returned even at a year to normal architecture. So if we take a look at the pathology of a grade 4 outer bridge lesion, which means all the cartilage is gone, and we have a surface of bone, and the surface of that bone is dead bone. But on the arthroscopic view on the left, you can see the blood supply is right up at the surface, even red. And on the gross specimen on the right, you can also see the darkened areas of vessels going from low to high up to the surface. And so what we learned even by opportunistic look arthroscopically, that a patient who came to have a knee scope for surgery, we see that there was actually bleeding and blood clot on the articular surface where the blood supply right at the surface of vessels had ruptured spontaneously and naturally and formed a blood clot over the surface. And on the right, you see the histology of the vascularity at the surface and the blood clot on the surface as well. So the end-stage degenerative arthritic lesion needed to be explored. And what we found and what we published was that the surface is dead osteons, but still has vascularity. The histology picture on the left shows you the empty osteons, the holes with no cells in them, and you see also the vessel right up next to the surface. But in addition, what's very important is that there are cartilage aggregates, as seen on the photograph on the right, that the cartilage has come right up to the surface in a natural history repair. This hadn't had any intervention or any surgery. So what we have on end-stage degenerative lesion is dead osteons, vascularity at the surface, and more importantly, cartilaginous aggregates right at the surface. But also, if we look at the exposed sclerotic bone histologically, we see 3 surface breaks. One is where the aggregates come up and not fully filling the area of the sclerotic bone. 2, where the vessels in the middle photomicrograph shows vessels coming right up and through the sclerotic bone. And 3, there are breaks in the surface of the sclerotic bone or bone fissures. Why are all those important? They're a future home for therapeutics as we learn more about biologics as time goes on. And this was published in the journal Knee in 2010. So what that led to was thinking about how could there be a cartilage repair? And it came up with the term arthroscopic abrasion arthroplasty, meaning that it was performed by arthroscopy, that an abrasion was made similar to a dermabrasion, very superficial debridement of the dead osteons, and we called it an arthroplasty because what happened afterwards. So these were people who came who were hoping to defer a total knee or maybe not have that, and their contraindications were, of course, if they didn't have good motion or if they had severe angulation of the joint. And so the other disadvantage was that we had to protect the blood clot that occurred on the joint. So remember, has to house and hold, has to be held. So they had 2 months of non-weight bearing crutches. And so what we learned the results were that a certain percentage, which was 50% did not have a total knee after 5 years. Now, you must remember these are people who didn't want one, and so they were motivated to do everything to cope with any discomfort that they had to avoid a total knee. So all of these peoples were Coper inclined. Now let's take a look at arthroscopic abrasion arthroplasty, where we're exploiting the pathological anatomy. On the arthroscopic slide on the left, we see a sclerotic lesion and exposed bone. And then we performed a 1 millimeter deep abrasion to remove the dead osteons from the surface because blood doesn't hold well over dead tissue. And then we had the bleeding. The bleeding then was protected, became a blood clot. And at 8 weeks, we saw that these people had a fibrocartilaginous resurfacing of the area, which was previously sclerotic and dead bone. So we take a look at the superficial 1 millimeter deep abrasion seen here on a histological specimen. And this was taken on not on a live specimen, but a person that had that arthritis. And we see that we expose the surface and that the blood vessels are right at the surface. So where this procedure would fail is if people did deeper than 1 millimeter abrasions, which were not necessary, but that is the key to success. So what was the biological response? Well, at 8 weeks, there was a fibrous tissue response seen on this photomicrograph. You see the bone below and you see the fibrous tissue above at 8 weeks. And at 4 months, the cell type had changed to a cartilage type of cell. And here's a biological cartilage surface repair seen on a gross specimen at 1 year, where a patient specimen was sent to me from a person that still had pain and underwent a total knee operation. And you can see the white area of repaired cartilage at 1 year. And if we take a look at the histological phenotype conversion, on the right lower, we see the intact normal bone and normal cartilage. The arrow is at the junction of the two, and over to the left and upper is the fibrocartilaginous repair seen at 1 year. And you can note down on the lower left where the vascularity is right at the surface. To the right, you see the area of the tide mark. And so we see that that abrasion, which removed the dead osteons, exposed the vascularity, allowed it for a blood clot that by 1 year had converted to a fibrocartilage tissue. And so on the left here on this view, you see a photomicrograph of fibrocartilage, but on the right, you see a histochemical view with sapho stain of what normal cartilage looks like in order to differentiate between the two. And so other opportunistic biopsies showed, here's a tide mark over the area of the abrasion arthroplasty seen at 4 years. So we have bone below, vascularity near the surface. We see the horizontal tide mark of the darkened area of a line of tissue. And then above, we see the articular cartilage, which now is taking on the characteristics of 4 years of normal hyaline cartilage. So what happened to these people? Well, one of the ways to follow them was what happened to the x-ray. So standing x-rays all had bone on bone preoperatively, but 50% of the people had wider joint spaces seen on standing AP x-rays of their knee as seen on the right radiograph. So then that made us think about autogenous bone grafting in small lesions. Now, one of the things that happens in discovery of science or art is one thing tends to lead to another. So we saw that we could have early healing over an area of osteoarthritic bone. What about areas that had defects like cortical cancellous graft could be done like we see on the left? And so what in these cases either had osteochondritis dissecans, where I had a fragment or a portion of the cartilage was available, but the adjacent area was then filled with a bone graft of the patient's own cancellous bone graft. And on the right lower, you see at 1 year a completely repaired articular surface having an autogenous bone graft to an area of exposed articular cartilage of the femur. And this was done with a percutaneous bone grafter. And we had what I might say limited success, but when we had cases that were successful, it was totally unbelievable in my mind, my observations. But the articular cartilage we saw had filled with the bone graft, and over to the right, we see the healing. So the other thing that we advanced from there was that we then had a method that was patented on a bone grafting of articular cartilage and the instrument that was like a large syringe to harvest and deliver autogenous bone graft. So what about the time factor? Does the tissue endure? Of course, the literature says it doesn't. But here we had arthroscopic views of area that had just a free autogenous bone graft made to the articular surface, and 6 years later, it's still an intact surface, asymptomatic patient. So we needed some more documentation, and so we published on 12 to 20-year follow-ups. Frankly, I think it's unbelievable, but also I should tell you that this paper's been ignored. And what we saw that if we biopsies between 12 and 21 years, we started to see first early on fibrocartilage, as you see on the photomicrograph to the right. And then, as one thing leads to another, this was a young man who had had leukemia treatment and lost a big surface of both knees articular cartilage. And so we did on the right knee, you see what it looked like at the time of surgery. We used bone graft from iliac crest and from the same tibia, proximal tibia, and bone graft is their knee on the medial condyle. And what's interesting is that was not a congruous physical bone grafting. But what we see 13 years later, same knee, right knee, that's the flexion that he has of his right knee. And you'll see the left knee, which had the same thing you'll see on the left, the extension on the left knee. And then we also did his left knee, and you'll see the flexion on the left knee and the extension on the right knee. So he had near normal ranges of motion, relatively asymptomatic, 13 years after this huge autogenous bone graft. So now if we're thinking, I wonder if articular cartilage will heal, here is a circumstance under the most adverse conditions that blood clot formed over this non-congruous surface and formed a cartilage surface. And so what we saw, MRI evidence that the tissue endures and survives from 13 to 20 years. As you can see, the arrow showing the large amount of cartilage formed over that area of bone graft 13 years before. And then what about the tissue conversion? Well, exposed bone graft on the left, upper arthroscopic view, an osteochondritic lesion partially fixed with a screw, and then the rest bone grafted below. A blood clot formed, as you see, immediately below. And then at 8 weeks, we had a biopsy, which you'll see showed a fibrocartilage at 8 weeks. But then 20 years later, he was willing to come back for another biopsy of that. You see the arthroscopic view of the intact lesion 20 years later. And then if we take a look at the patients who had the massive bone graft, we first see fibrocartilage as part of it, but on the right slide of the biopsy, we see the bone covered with a structure of normal appearing hyaline cartilage. So what we know is that the maturation of the tissue starts out as a blood clot, goes to fibrous tissue, goes to fibrocartilage, and over the period of 20 years can become and still remain intact and surviving as normal articular cartilage. And so here at 20 years is a regenerated tide mark. You also see the the articular cartilage above, again showing that there is a conversion from the blood clot to fibrous tissue to fibrocartilage. And if it lasts long enough, and it will endure 20 years, here is the normal articular cartilage. 13 years standing x-rays show that the joint space has been restored. And we can take a look at the left knee and before and after and see the restoration. And 13 years post-op MRI, again, more evidence that the fibrocartilage has now turned to more mature cartilage over the area of the bone graft. And you can see the area of the bone graft above the arrow and the MRI showing the articular cartilage. And here's 17 years on a patient, same young man, showing that still the articular surface has been maintained over those many years. And again, MRI show that the tissue has formed over that previously autogenous bone graft. Now, here's what I think is probably one of the most important papers in the literature. And it's also one of the more important they are, sometimes the more they're overlooked. This has to do with surgically unloading the knee. So first of all, we saw in the literature that patients who had an osteotomy or changed the angulation of the upper femur, before and after, we'd see that there was no joint space. One had then also occurred. And then Coventry reported where people had lost their joint space, had a varus abnormality, that if an osteotomy was occurred and realigned, that the fibrocartilage, or eventually probably articular cartilage, regenerated and gave a new joint space, but he didn't have any histological studies to show. But here's the important orthopedic publication. Guyton and Brand reported in the Clinical Orthopedic Related Research in 2002. And what they had was that they had patients who needed a total knee. And the one on the left is a preoperative view of a patient in 1967 who the opposite side had a total hip operation and without any instruction how to protect the opposite hip, started doing fine and didn't want to come back to have an operation. And so 11 years later, when they finally came back for an operation, we saw a regenerated surface. So on the left, preoperative, and the next slide over to the right, postoperative 11 years in a totally deformed situation, that's spontaneous regeneration of the articular cartilage. And then the second case they reported was even worse, where you see the preoperative x-ray, absolutely no joint space, complete destruction of the architecture of the femoral joint. You see on the right, 7 years later, when they came back to eventually have a total operation, we see regeneration of the articular surface and remolding of the bony tissues as well. So this is a case of spontaneous repair of the bony structure and of the articulating surface without any instruction. The patients just were able to protect that joint spontaneously because the total joint on the opposite side was where they put most of their weight. And so at 11 years, biopsies were taken in order to show what does the articular surface look like. And sure enough, it even had mature hyaline type cartilage. So what's we have here? We see that with spontaneous regeneration happened where they had reduced peak axial loads, meaning when they stepped on it, they protected it. There was no instruction, no ambulatory aid, no physical therapy, no medication, no injection, and no surgery. And yet regeneration, reformation of the bone, and regeneration of the articular surface. Now, there's some other supporting evidence in the literature as well. So 535 total hip specimens were looked at by Milgram and reported in 1983, long time ago. And what he saw was all these fibrocartilaginous regenerations of the surface seen in these people. Why did this happen? These people had a painful hip, and so they tended to spontaneously unload it, and therefore it allowed for the regeneration of these articular surfaces and the fibrocartilage and cartilaginous mature and these little aggregates at the surface. So again, we see no instruction, no ambulatory aid, no physical therapy, no medication, no injections, no surgery, and revision of the architecture of the upper femur and articular cartilage. So now let's take a look at other papers in the literature. This was a paper published in 2003 where we see the patient had severe changes of the articular cartilage, the medial femoral condyle, and had an osteotomy. And then for some reason, they're willing to have an open inspection of that area and shows what happened in regeneration after an osteotomy. So now we see increasing evidence that articular cartilage can heal. And here's another paper in the literature, post-op osteotomy. On the left, the arthroscopic view showing bone on bone on the femur and the tibia and a torn meniscus. And then after high tibial osteotomy, regeneration of the articular cartilaginous surfaces. How does this happen? It's a spontaneous response. So let's take a look at the gross anatomy of that sclerotic lesion again. This is a exposed piece of bone from a total knee showing the unstained and unseen lesion. But if we put methylene blue on the surface, we can see the pits in the surface, and we can see better the also the islands of cartilage regeneration, those aggregates also stained with methylene blue. And here's a close-up look of those areas of the regenerated spontaneous articular aggregates that have grown on the exposed bone. So then we took a look by arthroscopic surgery again, and we see some specimens that we show the aggregates have full stain on the left, and showing aggregates right near the surface, increased vascularity, and the histology on the right showing with methylene blue a articular cartilage aggregate spread out over the surface of the dead bone. So cartilaginous aggregates can be deep, they can be superficial, as the one on the left, but also you see the positive staining one deep where the arrow is below, as well as the arrow above. And this is cartilage cell morphology when you see a close-up of this histology of the lesion, reparative naturally on the left side. So then a study was done by Zhang and Myron Spector, and put my name on it, nice enough. And we took a look at these cartilaginous lesions with Sappho staining. We found out they had normal morphology, they had type 2 collagen, and they had small muscle aggregate, and they had leucin near the surface. So what have we learned is there is a natural history in the end stage osteoarthritic lesion to repair. However, it should be noted that only a grade 4 can regenerate it, because studies also showed that when the lesion was a partial thickness lesion, that there was no repair of the articular cartilage the same way as if it was a end stage osteosclerotic lesion. So how come do we have these edicts that cartilage cannot repair? Well, first of all, we have to have a famous doctor say that it's not so, they can't repair. Then they have to have some kind of studies by the literature, which they might provide some type of early finding that there was a fibrocartilage, but none of them went out 20 years. There was a lack of observation, a lack of curiosity, and frankly, I think it might have been superstition that they came to the conclusion articular cartilage could not heal. How come anybody could come to the conclusion that articular cartilage couldn't heal when we have all this evidence? So the only way it could happen is some famous doctor got misled and he said it couldn't happen. Then there was some literature that showed that if you had fibrocartilage, it wore off and wouldn't last. And that, of course, it was lack of observation, perhaps lack of curiosity. In my view, maybe it was just superstition. They didn't think it would work. Cartilage, if it is exposed to blood, doesn't have to have a blood supply, but exposed to blood, heals like any other tissue, forms a blood clot, converts to fibrous tissue. If it's housed and held, it will go on to fibrocartilage. It will survive. Why? Would you argue it wouldn't? Fibrocartilage is native to the joint. Non-weight bearing is critical in order to protect the blood clot from rubbing off. And the end stage osteoarthritis has potential to heal. And we showed that on histology and publications that it actually is normal articular cartilage in these aggregates. And then we lastly showed there's a clinical benefit. So here's the summary. Cartilage has the potential to repair. Cartilage has access to blood for the repair. Doesn't have to have a blood supply to have access to repair. The repair goes through the steps like any other tissue: bleeding, blood clot, fibrous tissue survives, maturation, and phenotype change over time. In fact, we showed that up to 20 years. Even end-stage osteoarthritis has an innate potential repair. That was shown with osteotomy and also with abrasion arthroplasty. What's the importance of non-weight bearing? Have to house and protect that blood clot. And there is a potential for long-term clinical benefit, which showed in absolutely the most worst case of a large lesion of the femoral condyle in a young man that had a bone graft that wasn't even congruous, and yet at 17 to 20 years, he had an excellent clinical result. And I thank you for listening.